and welcome to this Wolper Wellbeing webinar, hosted this evening by Wolper Jewish Hospital and Friends of Wolper. And our partner organisation this evening is the Stroke Recovery Association of New South Wales. And our topic tonight is stroke, reducing the risk of stroke and recovery from stroke. And my name is Julie McCrossin, and it's my great pleasure to be your host this evening. Let me begin by acknowledging that we're broadcasting to you from the land of the Gadigal people in the Sydney region, and we pay our respects to elders past, present and emerging. And just some quick housekeeping as more people join us. As usual, your questions are welcome throughout the whole webinar. You can put them in the Q&A, please. We cannot see or hear you, so the only way of bringing your questions to us is to put them in the Q&A. And thank you to the considerable number of people who've sent us questions in advance. Our question moderator this evening is General Practitioner Dr. Lena Safro, and she'll be coming in regularly once the panel discussion starts, and she'll bring questions to our panel that you're putting in the Q&A, and we'll answer as many as possible, but of course we can't give individual health or medical advice. And this webinar is being recorded and will be available on the Wolper Jewish Hospital website. Well, to begin, it's my pleasure to welcome the Vice President of the Board of Wolper Jewish Hospital, Josephine Holland.
Thank you, Julie. I appreciate this opportunity to just take a few moments to pause. At Wolper, we're very sad this week. We lost Dr. Alan Schell, who was an extraordinary gentleman, a man that has been involved with Wolper since he was a visiting medical practitioner first in 1980. And has maintained his commitment and his service to the hospital ever since. It's not just the Wolper community, I know, that is missing Dr. Schell and feeling his loss. Anyone who has been involved with dementia and the service that he provided to that community, as well as the Holdsworth community, his commitment to service and education. He was an extraordinary man. He was a very special man. He was a man of strong opinions, but he had extraordinary wisdom with that, and he had such grace and such patience. He had a very strong commitment to the state of Israel, and he loved Wolper. And particularly tonight, as we start this Wellbeing, I'd like to pay tribute to his enormous commitment to Wolper, and particularly this program. For many, many years, he was not only the heart and soul of Wolper and Wellbeing, but the face of this program. He was our mediator for many years, and we appreciated his grace and his wisdom and his enormous sense of humour in how he handled that position. And we would really like to pause and express our gratitude and our sense of loss at his passing. I would also like to pay my respects and wish long life to his wife, Roma, and to his children and grandchildren that survive him. In that spirit, I would also like to take a moment to remember the conflict that is ongoing in Israel at the moment with Gaza. Tonight, we remember and honour the incredible bravery and sacrifice of our soldiers, police officers, and all innocent victims of senseless terror. Our hearts ache for families who have experienced loss. We pray for the safe return of the hostages, the end of all loss of innocent life, and we hope for peace. Thank you, Julie.
Thank you so much, Josephine. And I'd like to express my own deep respect and affection for Dr. Alan Schell. You know, working with Alan on these community forums and webinars has been an enormous joy, and I can honestly say it's been one of the best work experiences of my life. He was quite simply a gorgeous man. He was a doctor with a profound commitment to growing the health literacy of not only the Wolper community, but indeed the broader community. And he was committed to empowering all of us as patients, or ideally in prevention, by giving us high quality health information. And I have had contact with Alan during his illness, and I just want to say he handled his recent health challenges with extraordinary stoicism and dignity. And I know I speak for everyone on the Wolper Wellbeing Forum team and all of you in our regular audience when I say how much we really are going to miss him, and may his memory be a blessing. Well, ladies and gentlemen and everyone, we turn now to our topic this evening, the prevention and recovery from stroke. And as you'll know, if you're one of our regulars, your questions are welcome all the way through the webinar, and you just pop them in the Q&A, and our question moderator, Dr. Alina Safro, will be looking at them, and she will come regularly during the panel and bring your questions. But to kick off proceedings, it's my enormous pleasure to welcome Michelle Sharkey, OAM, the CEO of the Stroke Recovery Association of New South Wales, and I'll give her some deaf sign clapping to make her welcome. Welcome, Michelle.
Thank you, Julie. And on behalf of the Stroke Recovery Association, I'd like to thank Wolper for inviting us along to be their community partner this evening. Stroke is one of those enormous issues facing our community. It is still one of the leading causes of death in Australia and the world, in fact. And in fact, it's also one of the leading causes of long-term disability and chronic illness. And I guess one of the reasons that this association is so passionate about prevention of stroke is that in order to ensure that people have a great quality of life, it's important to manage our risk factors and ensure that we don't have a stroke in the first place. Years ago, by the wonderful Anita Rosenberg, who had recovered from her stroke or was in the process of recovering from her stroke, and realised there needed to be support for people recovering from stroke ongoing. But still, to this day, part of that process of this organisation has been that emphasis on prevention. It's so important that getting the message of be fast, getting out there and getting to hospital quickly is so important. Knowing your risk factors is so essential to ensuring that, you know, we get to hospital to get the appropriate treatments that we need in order to get a good quality recovery. Amazing advances in stroke treatment over the last 30 years, brought on by tremendous research by our clinicians and also the practical people at the coalface. So it's important as we go into this area today that we listen to the wonderful team that Wolper has put together this evening, experts in their field on neurology and physiotherapy and all the areas that we need in order not only to live have a good recovery from stroke, but also to have an ongoing good quality of life. So I'd like to welcome everybody and thank you very much, and really hope you enjoyed the webinar this evening, and I hope it is a wonderful evening for everybody. Thank you.
Thank you so much, Michelle. I met Michelle, I think something like 25 years ago, so it's marvellous to still have you with us here this evening. Thank you. Well, ladies and gentlemen, if you've just joined us, welcome, and a reminder that your questions are welcome in the Q&A throughout the evening. Just before I bring our panel on and we begin our conversation, we're just doing a quick audience poll so they have a sense of who you are tonight. So what happens is we're going to put 5 questions up on the screen, and I'll read each one out. You'll pop your answers up, and then we'll give you the immediate overview of the answers from the entire group. So I'll ask our media whiz Nat to put up our first question. And it is your gender, male, female, other, prefer not to say. If you could just answer that question, please, on your computer screen. So we have 23% men, 77% women, and 1% other. Thank you very much. Our second question, please. Your age, 39 years old or younger, 40 to 60, 61 to 70, 71 years or older. So 2% are 39 or younger, 7% between 40 and 60, 13% 61 to 70, and 77% of our audience is 71 or over. Thank you. Our third question. Now, this one, of course, you can click as many as you wish. Do you or the person you're concerned about experience any of these? Difficulty following television shows or books, loss of the skills needed to do daily tasks, withdrawal from others, changes in behaviour, trouble concentrating, frequent confusion, forgetfulness, fatigue. If you could tick all the ones relevant to yourself or a person that you're concerned about. So difficulty following television shows or books, 17%. Loss of the skills needed to do daily tasks, 8%. Withdrawal from others, 13%. Changes in behaviour, 19%. Trouble concentrating, 28%. Frequent confusion, 12%. Forgetfulness, 47%. Thank you. We turn to our next question about prevention.
Oh, you missed one, fatigue.
Oh, I beg your pardon. I've got to remember to scroll down. Fatigue, thank you, 52%. Prevention, which of these, if any, apply to you? And you can tick as many as you wish. I engage in regular exercise. I control the amount of sugar in my diet. I don't smoke. I control my consumption of fatty foods. I eat fruits and vegetables regularly. I minimise alcohol intake. I keep my weight in a healthy range. I engage in regular exercise, 76%. I control the amount of sugar in my diet, 58%. I don't smoke, 96%. I just have to do a deaf sign clapping for that. I control my consumption of fatty foods, 71%. I eat fruit and vegetables regularly, 87%. I minimise alcohol intake, 81%. I keep my weight in a healthy range, 63%. And we have just one last question. Which of these, if any, apply to you? Just one answer, please. Do you have a family history of stroke? Have you ever had a stroke? Has someone close to you ever had a stroke? None of the above. I think you could answer more than one of that. So I'll answer as many of those as you wish, please. Evidently, you can only answer one, so choose your priority answer. My apologies for that. So do you have a family history of stroke? Yes to 23%. Have you ever had a stroke? 7% have. Has anyone close to you ever had a stroke? 28%. None of the above, 41%. Well, look, thank you so much for giving us that information for our panel, and it gives me great pleasure now to welcome all the panel to our screen this evening. I want to welcome Professor Coralie English, Professor of Physiotherapy at the University of Newcastle, Professor Vincent, a neurologist and clinician researcher at Austin Health, Professor Monique Kilkenny, an epidemiologist and health services researcher from Monash University, and Dr. Malcolm Bowman, a rehabilitation specialist and consultant at Wolper. And I'll give more information about our panel as I bring you onto screen. And I'm just checking I've got all my people. Are we able to add Professor Thijs? I can't. Yes. Thank you very much. Welcome. Look, thank you so much for coming. Now, the purpose of our panel this evening is to discuss reducing the risk of stroke and also recovery from stroke. And if I may begin with Dr. Vincent Thijs, a neurologist and clinical researcher, as I said, clinician researcher, specialising in stroke, director of neurology at Austin Health, and a leading researcher at the Florey Institute. Vincent, if I may call you that, could you begin by giving us a definition of stroke and explain the different types of stroke, please?
So a stroke is a common condition that affects the blood vessels in the brain. Our brain requires a lot of nutrients, oxygen, that is brought to the brain by the blood vessels. Now these blood vessels, they can become diseased themselves. And the two most common stroke types are where there's a blockage of a blood vessel, meaning that part of the brain doesn't get the necessary blood supply. That's called an ischemic stroke. And the second most common type of stroke is where a blood vessel within the brain starts leaking. Actually, it ruptures and damages due to the high pressure of the blood entering the brain tissue. And that's called a brain bleed or a brain hemorrhage. So ischemic strokes are very common, especially in Western society in Australia. But if you would go to Asia or China, the proportion of hemorrhages will increase quite a lot.
And why is that difference? Why is there a difference in the Asian area?
Well, we don't really understand why that is, but it probably has to do with high blood pressure and possibly some genetic factors that play a role in this difference in proportion.
Look, I'm going to discuss with you prevention. Obviously, people are terribly interested in that, but I thought it might be useful throughout the evening, every now and then, to talk about FAST, F-A-S-T, which I think stands for face, arms, speech, and time. Could you explain why everyone who watches this should memorize FAST and what it's fundamentally telling us?
Mm-hmm. So FAST is a test that can be used to recognize most strokes. And it's a test that in the pre-hospital setting, so at home or when an ambulance person comes and pick you up and assesses you, will have to do to determine whether you have a stroke. You can use it if you see somebody to assess whether they have a stroke. What you do is you look at a person's face and you can assess whether there's a droop. You make them smile and you see that the corner of my mouth goes up on both sides, but the person who will have a stroke may have only one part going up and have a facial droop. The second test is the arm test, and you ask a person to raise both arms, and you can check whether there's an imbalance, one will drop down. That's also indicative of a stroke. And then you ask the person to speak a sentence, and if it's slurred speech or incomprehensible speech, or they don't follow the command, that could also be indicative of a stroke. And then you have the time, meaning just an indication. Time is brain. If any organ, but especially the brain, is particularly vulnerable to lack of nutrients and oxygen. So the quicker you recognize the sign of a stroke, the quicker you alert the ambulance services. Don't call your GP, call the ambulance when somebody you're seeing or you're feeling these symptoms yourself. Call an ambulance. Don't call your GP. Don't wait for a relative to come in and check. Call the ambulance. Don't wait for the daughter to come in when something's wrong. Call the ambulance. Time is brain, because with every minute, about 2 million neurons die. So we can save a lot of brain by acting quicker. And that's a big barrier to our treatments, is they have to be administered quickly to be more effective.
Again, just staying on that acute moment for a second, people have asked about the clot busters. Can you just explain what that treatment is, and is it universally available in all hospitals? So we have panel and possibly some audience from both Melbourne and Sydney, or even more afield, although our predominant audience is Sydney. So what are clot busters, and where are they available?
So I told you that 80% of the strokes in Australia are due to a blockage of a blood vessel, and that's typically due to a clot. The clot typically originates in the heart or in the neck, but we can break up this clot by using a chemical, and this is what we call a clot buster. So a pharmaceutical agent that is administered intravenously, so via a blood line, to start to dissolve the clot and restore blood flow that way. Now, this solution of a clot can happen by pharmaceutical, but also now by a procedure called clot retrieval, which is a procedure done in highly specialized centers in Australia, mostly in metropolitan areas. Clot busters are accessible in most what we call primary stroke centers that can administer this, and most hospitals are linked up to a hospital that can help them give thrombolysis. Especially in New South Wales and in Victoria, there are definitely still gaps, but we try to cover as much as possible of these two states at the moment. Either they have in-house expertise to administer it, or they can call upon a team called a telemedicine team to help give these medications, or also to decide you need to be flown into Sydney or into Melbourne to get this treatment. And over the past 10 years, we've developed quite good systems to set that up. It's not perfect. It's not available everywhere. The smaller the hospital, the less the likelihood is that you will have access to this treatment, and that there will be delays because you have to be brought to another hospital and then maybe flown into Sydney or Melbourne. So it can be quite time consuming. I told you time is brain. So the quicker, the better, the more streamlined our systems are, the better we can deliver these highly effective. They're not perfect. Not everybody recovers, but they give you the best chance for recovery.
This expression, time is brain, certainly clarifies the mind. Could you just run us through the key risk factors, and then we'll move to prevention with yourself and also other members of our panel. But what are our key risk factors?
Well, first of all, we know that 80% of the stroke could be prevented. In an ideal world, if there were no risk factors, we could prevent 80% of the strokes. And there are medical risk factors, there are lifestyle risk factors. If, for instance, there were no high blood pressure in Australia, we probably would have half of the strokes we're seeing now. So high blood pressure is top. Cholesterol, smoking, diabetes, sedentary life. I've sat all day doing meetings, etc. And Coralie, who you will talk to, she's a big advocate for standing up every few minutes, or doing the meetings on team standing up, because it's a medicine. Moving around is very good for prevention and well-being. Food, Coralie is an expert on food and prevention. Adopting a Mediterranean diet that contains a lot of fish, few red meat, more vegetables and fruits. It's probably if you adopt that lifestyle, your chances of having a stroke will be less. So there's a lot of work to do. It starts probably relatively early on in life that we have to adopt these healthy habits so that they can have a long-term effect over time.
Look, what I will do,
not a risk factor, but Coralie will correct me, I think.
Well, look, we've got to meet Coralie. It's too exciting. Nat, could you just bring Coralie on? And hi, I should just properly introduce you. Professor Coralie English has joined us, Professor of Physiotherapy at the University of Newcastle, a leading researcher at the Hunter Medical Research Institute. And I think, Coralie, your focus is on multidisciplinary global collaborations to improve the lives of people living with stroke. In order, because I'm a great believer in visual imagery helping to get messages into people's minds. If possible, Vincent and Coralie, could you just stand up?
Oh,
I think
then I have to lift up my I should be standing. I do have an up-down desk. I didn't put up. It's too late at night.
But let me just come to you on key messages of prevention. I know you're very involved too with people who are living with the effects of stroke, but again, your message to people, knowing that a very significant proportion of our audience are over 71. So the message that the prevention of stroke is a lifelong task that Professor Thijs has just told us is, of course, a bit challenging. I turned 70 myself in October. But what are the keys to prevention that you'd like to share with the audience?
Yeah, no, thanks, Julie. It's never too late to start. So yes, while Vincent said the earlier the better, it doesn't mean that all is lost. So yeah, Vincent covered all those risk factors. The one thing you forgot, Vincent, that I think is important for people to remember is irregular heartbeat. So if you've got any signs of irregular heartbeat, there's one in particular called atrial fibrillation. But if you're concerned that your heart's feeling a bit funny, you should absolutely get that checked out as well. The reason why I'm very passionate about the prevention and what we call secondary prevention, which means helping people who've had a stroke reduce their risk of having another one, is the physical activity and diet risk factors. They are what we call independent risk factors. So even if everything else is well controlled, if you are a couch potato, your risk goes up. But also those two things, physical activity and diet, they directly influence just about every other risk factor. On their own, they will reduce your blood pressure. They won't help your poor heart rate, but they will improve your diabetes control, improve your cholesterol. Less alcohol is better. You have to make your own decisions about giving up smoking. But they're, as Vincent says, physical activity and food is medicine.
And you focus very much on multidisciplinary care for the individual, don't you? And I assume that's both in relation to the preventative activities and the recovery. So tell us about, why do you do multidisciplinary research, and why is a team approach critical? Well,
because stroke affects every part of the body, really, and there are so many different effects. So the fast message is really important. So, you know, I want to make sure everyone remembers that one, and it picks up many of the common signs, but it doesn't pick up all of them. And also, just to reiterate, any one of those signs on their own is a concern. It does not have to be all of them. So any of those things, but also if you're feeling unbalanced, if you've got visual disturbances, there are lots of things that could indicate a stroke. But the fast message is the most important. I'm an expert, particularly in physical activity. I joke with my dietetics colleague that I need an honorary doctorate in dietetics, because I've done quite a lot of research in that space too. But I'm not a speech pathologist. Recovery of speech is really important. Obviously, we need our doctors involved and our nursing staff. So because stroke affects us so many parts of someone's body and life, we really need that team approach. And research is a team sport. If we're going to be trying to find better answers to help people recover better, to prevent more strokes, we have to get everyone together to answer those problems. And we have to work together around the globe so that we're not wasting research efforts, and so that we are all pulling in the same direction to get some better breakthroughs. We're a lot further along the track than we were when I was a baby physio, but we need more.
And could I just ask you, is there current research that is bringing more hope for the future? And what have been some of the key improvements in the prevention and response to stroke? If I could come to you, Professor Thijs, first, and then to Coralie, just give us a sense of recent innovations that have been bringing hope, and then what may be on the horizon.
Well, I think I have spoken mostly about the acute treatment, the clot busters, and the clot retrieval. I think these have really put stroke in the spotlight, and they have contributed to dramatically better outcome for certain people with stroke. We're still fine-tuning to whom it applies, how late after stroke we still can use it. But that is certainly the two biggest breakthroughs I have seen in my life in acute care for stroke patients. Another one that I need to mention, and coming back to the theme of multidisciplinary approach, is the stroke unit. This is a very low-cost intervention that can be implemented worldwide in every hospital, should ideally, that sees a number of patients, should ideally have an area dedicated to stroke where there's an expert team of allied health, physios, nursing, speech therapists, and a doctor who are taking care of stroke patients and approach these patients with a uniform approach. And if you do that, you also dramatically improve outcomes, not for those people that come in early or only the young or the old, it works for everyone. And that is really important, that we try to increase the rate of stroke units. And there's a whole program to certify stroke units now across Australia, just to increase the awareness and to make sure that our public health system creates the capacity to treat everyone equally. So very important breakthrough that I've witnessed. Implementation of stroke unit, thrombolysis, and thrombectomy over the last 25 years that I've been in stroke.
And just explain those two words again, thrombolysis and the other word you said. The
clot buster and the clot retrieval.
Thank you. Thank you very much.
And just as a sideline, Australia has been really instrumental in this. So we can be very proud of the whole research team that has helped the world get used to these treatments. So really important work that has been done and that we are hopefully continuing.
Could I just quickly ask you, I understand there's a trial about to occur, or it may have started in Adelaide, of a new piece of technology that can be used in the ambulance. Are you able to explain that to us?
Yeah, one of the problems, like I told you, there are two big types of strokes, and a brain hemorrhage, the brain bleeding where the blood vessel ruptures, requires a different approach. We cannot give a clot buster. We cannot use the retrieval technique for these patients. But when they happen at home, or when their person has a stroke and we're in the first moments, we cannot say, based on the clinical exam only, that this person is having a clot that blocks a blood vessel or a brain bleeding. So we need to use a technique, bring the patient into the hospital usually, use a CT scanner or an MRI scan to make that distinction. Now, we're losing time. We have to bring the person into the hospital, can take a while. Some people live very remotely, they have no access to CT scans. So and these machines are bulky, they're costly. So we're trying to find a way to cheaply and put these things in even ambulances or smaller health centers. And now we're trying to, and in Adelaide, they have developed a machine with funding from the government to create a new type of machine that is lightweight and can be installed even in a plane, a helicopter, just to bring more of the hospital closer to the place where the stroke occurs and where the treatment needs to be given as quickly as possible. So if we then diagnose a stroke immediately after discovery, and we say, oh, it's a blood vessel blockage, we can give the clot buster immediately.
Yep.
And so we're winning a lot of time by doing that.
Yes, time is brain. I'm never going to forget that phrase. Coralie, is there something you'd like to say about either recent improvements or research on the horizon?
Yeah, thanks, Julie. Yeah, I think Vincent has touched on the two biggest breakthroughs around the acute management. You know, in the recovery space, we're often saying we're waiting for our TPA moment. You know, we're waiting for that big breakthrough that's going to really accelerate our knowledge of promoting recovery. And when I say waiting, we're not really waiting. We're working as hard as we can to find those breakthroughs. I think we do know a lot more about the best sorts of therapy. So, you know, we can drill right down into better details now about what's the best sort of physio, the best sort of speech therapy for people to have. And the one of the breakthroughs, I think it's not a direct health service breakthrough. One of the breakthroughs we've done in Australia is we now have what are known as living clinical guidelines. So health practitioners often look to the clinical guidelines to say what's the best treatment for whatever. We have a comprehensive stroke guideline, and we were the only living stroke guideline in the world, and we were the first Australian living guideline of anything. So that's available on our Stroke Foundation website. And it means that we are constantly updating the evidence so that health professionals know to almost the day, maybe not the day, but certainly, you know, as soon as there's a breakthrough in the research, it gets put into our guidelines very, very quickly. So I think that has really revolutionized. There's no excuse for clinicians working with people with stroke not to know what the best care is.
And what's the significance of that word living at the front of the...
Yeah, sorry. So traditionally, when we write clinical guidelines, it takes at least 2-year process for us to look at what our current recommendations are, look at all the current research, and then update it. And then the problem with then guidelines is as soon as they're published, they pretty much immediately get out of date. An example of that from the most recent update we did was published in 2017. We started it in 2015. The old ones were 2010. So it was 7 years between the old guidelines and new guidelines. Pretty much the week after they got endorsed by the government, we had new research to say we can give that clot retrieval treatment much quicker than we used to. There was good evidence you could do it even earlier, which would mean saving more lives. And we could turn that evidence around, do the proper process that you have to do to get our guidelines updated. I think it was within a month. Whereas otherwise, it would have been another 7 years. And while lots of clinicians and doctors on the ground would have known that, it doesn't mean that the services change in response. So it means that we're constantly reviewing the evidence and the new research.
Look, it sounds fabulous. Look, if you've just joined us, we're talking to Professor Coralie English, a professor of physiotherapy at the University of Newcastle, and Professor Vincent Thijs, a neurologist and researcher from Austin Health. And we will come back to them, and I've got 2 more panel members to introduce, but I'd like to bring on our question moderator, Dr. Lena Safro, to just get a couple of questions from our audience, and I'll bring in our other panel members as we go. So Lena, if you could join us, and I can hear some questions.
Sure, thank you, Julie. We've got quite a few questions from people wanting to know their risk factors, and I'll read them out one by one. Family history of strokes comes up quite a lot. Can anyone comment?
Okay, look, thank you. And for some reason, I can't see Lena, but Nat might be able to explain that. I'm not seeing her on my screen at the moment. Yes. But the question of a genetic risk factor, can I come to you, please, Professor Vincent Thijs, on that? And if we could have the whole panel on the screen, please, Nat? I might have everybody on, please.
Yes, it's a risk factor. If you have a relative, a first-degree relative who has had a stroke, you're at higher risk yourself of having a stroke. Whether that's necessarily genetic, it's not entirely, probably partially genetic and partially environmental, because we also inherit habits, food habits, sedentary habits from the people we live around. The most extreme example is being overweight is sort of spreading like an epidemic amongst, so if you have one overweight person, the next of kin also has a higher chance of being overweight. So there is, and that's not necessarily genetic. So it's important to know that it doesn't mean that it's a fixed risk. If you have a family history of stroke, there's still something you can do about it. In rare circumstances, stroke does occur in families, but this is really rare. On a population basis, almost negligible.
Look, I'd like to welcome, if I may, Professor Monique Kilkenny, who's an epidemiologist and health services researcher at Monash University and head of big data, epidemiology and prevention, and with a focus on stroke. And I just bring you in. Can you just explain what you do with big data and whether you have a comment to make, for example, on genetic risk factors or family history?
So I just, first of all, just wanted to make some comments about what Vincent and Coralie were saying, is that we are really lucky to live in Australia. I've been working with the Stroke Foundation and the Australian Stroke Clinical Registry since 2007. And what we've shown is that these treatments have improved over time. So when Vincent was talking before about stroke unit, when I started, 1 in 2 people managed to be treated in a stroke unit, and now we're having 3 in 4. So we've really improved care. And also what Vincent was talking about was a clot busting drug, or the drug that dissolves the clot in your brain, that we used to have 3% of the population would receive that treatment, and now it's about 1 in 5 of those who have ischemic stroke, and it's improving all the time. And one of the things that Vincent didn't mention before, which I think would be really nice for him to talk about, is also in Melbourne, and I think there's going to be another one in Melbourne, is the stroke ambulance. So if you live close to the Royal Melbourne or Monash Medical Centre, if you call an ambulance, you might get a stroke ambulance. And within that ambulance at the moment, they have a CT scanner. They can check whether it's a clot or hemorrhage, and if it's a clot, then they can give you that clot busting drug. So, and that goes back to the living guidelines that Coralie was talking about. We monitor through the Australian Stroke Clinical Registry what care people are receiving in hospitals around Australia, not only in the acute setting when they've had a stroke, but also in the rehab setting, to make sure, are they seeing a physiotherapist? Are they seeing a speech pathologist? Are they being discharged on appropriate medications, such as blood pressure lowering medications or lipid lowering medications? So the living guidelines are also monitored through the audit system as well as the registry program.
What strikes me, Professor Kilkenny, as I listen to you and the others, is the variability of access to the best possible care. I mean, it really is postcode health, isn't it? Depending on where you are. I mean, when you say we've more people have got access to, I think you said 1 in 5, and now it's. Can you just?
So it's around 3% in 2007. It's about 20%. Some hospitals, it's 30% where the patients receive thrombolysis.
And I guess I just think, oh my God, that's not enough.
Yeah, we still can do better, and that's to do with the FAST message. We need to get these people to the hospital quicker. So if you see a friend, or you realise yourself that you've got slurred speech, or your face is drooped, you've looked in the mirror, call an ambulance. Because time is an essence to get to the hospital quickly.
So just again, if you could just explain what big data means, and then some of the other key lessons you've learned from it in relation to stroke.
Yes, I've in the last 30 years, I've worked in research, and the last 20 in stroke. And what we do with the registry, the Australian Stroke Clinical Registry, is we link to other administrative data sets. So when you get admitted into hospital, we can find out, your admissions. We link to the admissions data sets, whether you go to emergency department, when you go to the GP, general practitioner, or the PBS, when you go to the pharmacy, you get a pharmacy script, or whether you go to rehabilitation or aged care. And so what we do with big data is we link all these different data sets, and what we want to do is understand the stroke continuum of care. So by using these big data sets, we could understand, are people after their stroke adhering to their medications? How many people are surviving after the stroke? How many people are readmitted after their stroke? And then we can also understand what happened prior to the stroke, how we can prevent these strokes.
How common is stroke?
Very common. So one in 4 people will experience a stroke in a lifetime over age 25 years.
That's a sobering number.
It is.
And when I spoke to you before this our webinar, you said one of your key messages is to manage high blood pressure. Can you speak to that? What's the evidence there?
So that's the biggest risk factor for stroke. If there's anything you can do, is to manage your blood pressure. So go and get a blood pressure monitor for home and check your blood pressure. Even if you're on medication, go and check to make sure that the medication is working for you. And if it's not working for you, you need to go back to your general practitioner. And also the other thing it's really promote is the government introduced these things called a heart health check. And so if you go to the general practitioner, which I think someone else will probably talk about a bit more than me, it's good to have a heart health check, and they'll check your cholesterol, diabetes, as well as high blood pressure.
And talk about the chronic care plans that you can get from your general practitioner as well, and why you think that's important for people to know about.
Yes, so we did a big data project. We linked the registry to the PBS and MBS, and what we found was those patients who had a stroke and were provided a chronic disease management plan had much better survival than those patients who didn't get a chronic disease management plan after their stroke. And more importantly, what we found with this project is those patients who had a chronic disease management plan were more likely to adhere to their medications. Because what we've found in our big data analysis that we're finding that around 1 in 3 patients are discontinuing their medications. They're not realising they need to take these medications for the rest of their life.
And how significant a risk is it to discontinue your medication after a stroke?
You're going to have a recurrent stroke, especially if it's high blood pressure. You really need to take these medications, either the lipid-lowering medications or blood pressure-lowering medications or antithrombotics.
And just tell us about your Love Your Brain digital platform that I think you're going to launch next year, because our audience do love to know sources of more information.
Yes, so I'm very excited about this project. I just got a text message from one of my friends who's piloting at the moment. So you are welcome to be part of the project and pilot this digital platform. And so not only do I work in big data, but I'm really passionate about health promotion. What we want to do is prevent that first stroke, because stroke impacts all your wellbeing, as Coralie mentioned before, cause fatigue, problem visions, speaking, walking, eating, everything. So this digital platform is a way of, it's a spin-off from the Stroke Safe presentations, which the Stroke Foundation run. And it's about, they have a presentation that you can, volunteers run, and it's about extending that presentation to a digital platform so that it's accessible for all Australians and maybe for the world to learn more, to take action and prevent stroke.
Look, thank you. I'm coming back to your questions in a moment. I promise you. I just want to introduce our last panel member, Dr. Malcolm Bowman, who's a rehabilitation specialist and consultant at Wolper Jewish Hospital. And because I'm aware that some people are watching who've had stroke, and I think you see the survivors and there is life after stroke. But that the process of recovery can be slow and it requires considerable commitment. Can you speak to that? What does the post-stroke survivor need to do to increase their functional capacity?
Yeah, thanks. So I guess just following on from the other 3 speakers, the one thing we know now after stroke is that is the value of sort of coordinated rehabilitations, multidisciplinary. So a team approach of therapists, each sort of with the goals that they make in discussion with the patient and their family. But that them also then working as a team with the other therapists on the same page to sort of achieve the bigger goals. Things like returning home, returning to independence, community activities, driving, work, those sorts of things. So I guess the important thing from the patient's perspective, I guess, is to engage with the therapists and all the health professionals. Keep the discussion open. Ask questions, and stick with it. It is a long haul, I think, rehabilitation following a stroke. That's one thing we know. The process starts in hospital, but then it moves to outpatients, and then it moves to your own exercises under the guidance of therapists.
And you indicated to me when we spoke that if people keep that commitment, keep working towards incremental improvement, even 2 years plus, people can be improving. I just want to quickly mention depression, because as I understand it, 25% of people after stroke can be subject to depression. I had cancer a few years ago and experienced depression for the first time, and it's a rotten experience to have. So how critical is reaching out for the right treatment for depression if you're feeling that you are depressed?
Yeah, look, it's really important because, as you said, it's extremely common. We give at least a quarter of people, possibly even more than that in some studies. It's a real problem as well. It's for a variety of reasons. Obviously, having a stroke is enough to make a person feel down, but I think there's also evidence that it's more than that. It's also damaged brain cells will release various chemicals and that sort of thing that also have a depressing effect. There's also, combined with depression, anxiety as well, uncertainty. So the important thing, I think, if there is any of those symptoms, is firstly to engage with your health professionals about it, to have a diagnosis. Second, also your doctor can also see if there's any other thing that may be contributing to that, if there's any other medications you're taking perhaps that may, we know that some medications like benzodiazepines, for example, can make a person feel more depressed, and also, and then sort of look at the treatment approaches. I think if an antidepressant is recommended, I think there is good evidence that can help as well. It's important, I think, to get onto depression because it can affect recovery. It affects the response you get from the therapy that you're receiving. Yeah.
Exactly, and your commitment to it. Look, just before I just want to go for the rest of our time to questions, I just want to ask Professor Vincent Thijs, is there anything you'd like to comment on that has been said? And there was that direct reference to learning about the trial in Melbourne ambulances that was referred to earlier. But any comments you'd like to make, please?
Everything that has been said is obviously correct with the expert panel. I think what I would like to highlight is that the stroke never finishes for most people. It's a lifelong struggle to a various extent, and it depends on a lot of factors, including the family, the peer support you have, your own resilience. But it's hard to identify a person who says, I'm completely back to normal. And that's often not, the physical consequences are often obvious, but often what we hear is things that are invisible. The cognitive complaints, memory complaints, fatigue, all these things are accentuated in people that have experienced a stroke. And often the healthcare system is not very well targeted towards those problems, and also our patients often don't talk about these problems as openly as, and also doctors feel uncomfortable to talk about them because we often don't, and we have to admit, we don't have a solution for everything. At least acknowledging and knowing that it exists and referring on to the appropriate health specialist that has solutions is often what we see is not happening enough. And I think that's really important, that we the medical system can do its bit and should do its bit, but also we need within our community an awareness. And many people are very frustrated. They say, oh, you've recovered so well from your stroke. And a stroke survivor will say, well, that's not how I feel.
Yes.
And that's something we have to acknowledge. And maybe with your experience with cancer, it's the same. but I think the quality of life, and Monique can comment on this, the quality of life among stroke survivors is actually as poor as a cancer survivor. So we need to be focused on well-being, and that's why I think your institution also is important.
Could I just have a quick comment on? I'm just very aware that our partner this evening is the Stroke Recovery Association New South Wales, and a number of years ago I hosted a public forum for them in Sydney where a lot of people who'd had strokes were there. And as a cancer survivor, I'm also aware of the value of peer support, contact with other people who've gone. I had a throat cancer, and I don't show a lot of the structural damage to the head that many people who've had head and neck cancer have, but I have psychological challenges. And thank you. Michelle if I could ask you, Michelle, to come on for a second and just say something about peer support and also the role of supporting the family. Welcome to our CEO from the organisation.
Thank you, Julie. Yeah, peer support is absolutely crucial, quite frankly. It's an enormous part of recovery from stroke. And we run 35, 40 to 40 stroke recovery clubs throughout New South Wales. And the value that people get by going along and reconnecting with their community through meeting with other people who've shared the same experience that they have. And people have, I think the experts have touched on it very much tonight, that people recover from stroke in various ways. And the physical recovery from stroke is important, and the cognitive recovery from stroke is important, but the social recovery from stroke is essential. And unless people reconnect with their community and with other people around them, they tend to be very isolated and lead a very lonely life. And I think the National Stroke Foundation statistics are about 64% of people will suffer depression as a result of having a stroke. But going along to our stroke recovery clubs can assist people to really reconnect and re-engage with people. And one of my lovely stories that I remember is that I went to a stroke recovery club many years ago, and this lovely lady said to me, "Would you mind waiting? My husband wishes to speak to you." So he very gradually came across to have a chat, and he said to me, "You bullied my wife into bringing me here. And I have to say thank you. It was the best thing I've ever done." He said, "because I was sitting at home alone and just waiting to die until I came along to this group and reconnected with people who made my life worthwhile." And I think peer support, that's a real summary, I think, of peer support and the importance it plays in people's lives and the value of social support in their recovery.
Well, thank you so much. What I'm going to do now is come to Dr. Lena Safro, and we're going to try and get through as many questions as we can. So I feel if I could ask for brevity to the extent that is necessary to obviously answer the question. So Lena, another question, please.
So we've got quite a lot of questions here in the Q&A box. Many of them seem to be related to a whole host of medical conditions, which may or may not be associated with the risk of stroke or may be a precursor of stroke. So Julie, maybe I can just list them one by one and have a brief comment from our experts.
Would it be useful perhaps to read the whole list, and then I might come to Vincent, Professor Thijs, and he can comment on them as a group? Is that okay?
We can give it a go.
Yeah, well, let's see. Let's just get the overview of where we're heading, and then I'll ask Professor Thijs for how he'd like to do it. Yeah.
Sure. So top of the list is what people call mini strokes or TIAs, the transient ischemic attacks. How are they a precursor of a stroke and how to deal with them?
Okay, let's do them one at a time. I should take advice from my general practitioner. Vincent, your answer, please.
Very important. TIAs are strokes, but they last only a few minutes. They're very brief. They're as dangerous as a stroke. They're a risk of having a stroke imminently. They need urgent action. They should be considered as a stroke. Shouldn't wait at home. You should call the ambulance. I have been unable to speak for 5 minutes. Oh, I noticed my partner had a droop in his face and it resolved completely. Or the arm, I couldn't use my arm this morning while I was shaving. Don't disregard these symptoms. Go to hospital.
And if you do go to hospital, what is the likely action you can take to try and prevent it becoming more significant?
Well, we can start all these prevention measures very early on, and we know that is highly effective. If you take a blood thinner relatively rapidly after a TIA, you reduce your risk of a stroke happening the next day or within a couple of hours dramatically. So it's ultra early rapid prevention that you're doing. So that's really important. Also, if a stroke then still happens, you're in the right spot to get treated. So very important to not disregard these symptoms.
I know this is anecdotal and not big data, if I could say, Monique, but I happen to know two gentlemen who've had TIAs and who've done the right thing, and many years later are still working community members who haven't had further danger. So I touch wood as I say it, but I always like to offer some hope, even if it's anecdotal. Is there anyone else who'd like to comment on that before we come to the next one? No? The next one, Lena, please.
Sure. So the next one, I'll give you two: tinnitus and sleep apnea. People would like to know if either of these is associated with the risk of stroke.
Tinnitus very rarely, and sleep apnea means a lot of things in your body often are wrong. You're overweight, you're at risk of atrial fibrillation. So yes, indirectly, risk factor for stroke.
Okay. Next, please.
Can I just add one other thing there that we need to talk about also is about having a vaccine for influenza. That actually can be a prevention, especially when you're older, for a cardiovascular event, and as well as HPV. So there's evidence for that. So making sure that you go to GP and up to date with your vaccines too.
Thank you. And I should have asked Coralie or Malcolm, would you like to comment on anything we've said so far?
No, I think it's important to remember just to highlight again what Vincent said about the TIA. Any symptoms, don't ignore them. They're a sign. But also my grandmother's another anecdotal evidence, Julie. She had a TIA. I still remember I was a physio student and she lived to her late 80s on all the anti-prevention medications and never had a stroke. So absolutely don't ignore anything, no matter how transient it is.
I guess one of the, did you want to say something, Malcolm?
Oh, no, I just agree. I'd say it again. It's just so important to seek urgent treatment with any of those symptoms. Yes. Yeah.
It's this question of speed. Time is brain, is the original comment from Professor Thijs. You know, that thing of don't hesitate, ring 000. I'll add one more anecdote. My late 94-year-old mother, who had every risk factor you can imagine, and she was one to ring the ambulance, and I think was critical in her long-term survival. And in my experience, ambos are always cheerful on arrival, and they have systems for prioritizing people and knowing who you are. So, you know, don't hesitate for a second. They're like the firemen or fire people. They never say you shouldn't have rung. They're always supportive. But Lena, another condition, please.
All right. So the next one is vascular dementia. Is this related to stroke, and does it increase your risk of stroke?
Yes, vascular dementia is an increasingly recognized type of dementia due to disease of the blood vessels in the brain. Typically also linked of people will have had a stroke, but rarely people will not have had a stroke, but have progressive damage to their blood vessel, and that's why their brain isn't functioning as well. Often, actually, the older we get, there is a mix of Alzheimer's and blood vessel damage contributing to dementia. So yes, it's related. The good news is we can prevent them. 80% of strokes can be prevented, and probably with all these measures, we're preventing dementia as well.
Okay, thank you. Coralie, would you like to comment?
On the vascular dementia?
Yeah.
Yeah, I mean, I think Vincent's across all of the medical risk factors, but yeah, just to pick up on his last comment, all of the things that we can do to prevent stroke will prevent everything else, you know, that will help reduce your risk of cancer, will help reduce your risk of heart disease. So there's another line that researchers often use is what's good for the heart is good for the brain. So all of those, we call them lifestyle. I don't really like that term, but all the things that we can do to keep ourselves healthy in terms of keeping active, eating well, getting our regular checks. If we need medications, keeping onto those medications will also help reduce your risk of vascular dementia or any other sort of dementia as well.
Just so I don't forget, you've been involved with an eye rebound website in the United Kingdom, but obviously it's relevant internationally. Just quickly explain that as a source of information for people listening tonight.
So that's actually Australian, Julie. It's not from the UK. It's here. So, and to Malcolm's point and Michelle's around support, I kind of wish we'd had the foresight to think about bringing a stroke survivor into this panel as well. All of my research now is done in partnership with people who have a stroke, who've had a stroke. And the website that we built, it's hosted by the Stroke Foundation. It's called iRebound. Even the name iRebound came from the stroke survivors, saying we want positive messages about life after stroke. And it's a website that includes information about living well. So there's exercise programs that feature people with stroke exercising. There's diet advice and recipes. And there's a huge hints and hacks section that was basically crowdsourced by people living with stroke about all their hints and hacks. So that's a really great website for people who've had a stroke or carers or people who've got loved ones with stroke to go to. But the Stroke Foundation has piles of excellent information on there as well, and a stroke helpline that I just want to give a quick shout out to as well. If you can just Google stroke helpline or look it up. They're a phone service. They also have chat support. So any questions that you have about for yourself or family member, that's a really useful place to go.
I'm just going to say something, and Vincent, please correct me if I'm wrong, but I happen to have known some elderly people with fairly significant vascular dementia who still lived a good life. You know, and I just wanted to say that, I suppose. Yes, cognitive capacity was reduced. There was a little bit more repetition, but they were certainly still able to enjoy life and engage socially. Is that correct, Vincent, in terms of what can happen with a patient?
Absolutely correct.
No, well, thank you. Again, it's just this hope thing, because there's something very frightening about stroke, I have to say. Lena, is there another condition or another question?
Sure, just to segue from what you just said, Julie, someone wants to have some advice for people living alone. What should they do if they suspect they might be having a stroke?
Wow. What do you want to go first, Vincent?
Well, I think call 000. If you're worried about having a stroke, they will guide you through. They will ask the right questions, and then send an ambulance if required. So yes, please. Of course, social engagement is really important, and peer support is important too amongst elderly people. Yes.
I'd just simply add, and others can comment if they wish, but you know, you can get services where you wear something around your neck and there's a button to press. And certainly with, I'm sure there's many people watching who would have one, or they've assisted a member of their family to have one, so that if for any reason you can't move to the telephone, you press this, and they have different systems so they can contact and get in touch with you, or just gets an ambulance to you. Lena, another question, please.
Sure, lots of questions, Julie. I know that we don't usually talk about specific medications, but this one was bound to come up. How useful is Ozempic in preventing stroke? Lots of people want to know.
So Ozempic is probably, for those that don't know, this is the weight loss drug. It's originally developed as a diabetes drug, but now has been proven in high dose to reduce weight as well. And a large study came out about a year ago where they tested in people that were at high risk of stroke or a heart attack whether it provided additional benefit. And it did. It reduced the rate of mostly heart attack and heart-related deaths, less so stroke, but there are some other studies that are suggesting that it may also help for stroke. It's not in the guidelines at the moment. The dosage is, as you know, there's a shortage in the world. so that people with diabetes cannot access it. But it's a promising thing. Whether how our society will pay for that, that's another question.
Would anyone else like to comment on that question? Because golly, that's hot in the community.
I think the main thing is good control of your diabetes. So, you know, I agree with Vincent, we don't know enough about it. We're certainly nowhere near suggesting that people go on it as a prevention, and there are so many people need the drug for the management of their diabetes. We don't know a lot about the long-term effects. So all of the things we've been talking about, physical activity, good healthy diet, regular checks in terms of diabetes, and maintaining the control of that really well is the number one.
And Monique, with your big data activities, will you be doing work around OzMP?
If we can in the future definitely look at the use of OzMP before stroke and before a heart attack, but at this stage we haven't had any plans. That's something we could look at definitely.
And Coralie, I know you're involved in all sorts of collaborative international research. Is there sufficient funding for stroke-related research?
No, Julie, sadly not. You know, for a condition that 1 in 4 people will have, and worldwide it's the leading cause of death and disability, it attracts minuscule proportion of funding in Australia. I mean, Australia doesn't spend enough on research and development to start with, but the proportion that goes to stroke is very, very small. And we don't know why that is, whether it's not a sexy enough disease, I don't know. And our Stroke Foundation tries to do as much as we can to fill that gap. We have a small grants program, but even if you look at the size of our foundation versus the Heart Foundation, which gets a whole lot, like more than 10 times the funding and support from the community, there's a real need for more investment in research so we can have better breakthroughs in better recovery, better prevention.
Could I come to you, Vincent? I just want to talk about age for a second. So first of all, is greater age a risk factor? Like as we're older, are we more at risk? But I also want to ask you about your work with young stroke, people who are young who have stroke. But first of all, is age a risk factor for stroke?
Yes, the older we get, the higher the risk of stroke is, and that is definitely well proven. It's particularly if you're over 85, your risk of having a stroke is 6-fold the risk of when you're 65. So it really increases quite a lot. But there is a substantial proportion of people, about 6,000 a year, we think, in Australia that have a stroke before they're 60, 55. There's a large proportion of people that have a stroke between 18 and 45, and there are even babies and children that have strokes. Now, of course, when a stroke happens at that stage in your life, it's very different than when it occurs when you're 70 or 75. Because most strokes occur in the older people that have a stroke at a younger age, they feel that they're not being helped as well, because the services are geared towards getting back to the community, getting back to home, of course, but a young stroke person, they want to work, they want to take care of their children, they have the relationships. It's such a different life stage to having a stroke. So we're developing a system that really addresses the needs of young stroke survivors, especially focusing on return to work, return to driving, focus on dealing with memory, with anxiety and depression, things that are really highly frequent amongst younger stroke survivors. We're also helping them to get their peer support going. And because, for instance, if they would go to most stroke associations and stroke support groups, their experience of stroke is very different when you're 18 and you're put amongst people that are 65 and older. It doesn't connect, it doesn't gel as easily, of course. And that's why we're focusing, and we're hoping that we can roll out this service over when our grant finishes. We want to expand. We want to offer this throughout Australia. Currently, it's restricted to Victoria and South Australia as a pilot, but we're advocating that we will get this service up and running all over Australia.
May it be so. That's so important. Would anyone else like to comment on that younger stroke recovery issue and what we need? Just double. Michelle, thank you.
Yes, I'd like to comment on that because it is quite important that younger strokes get particular services, and they have different issues. They've got a lifetime of living with chronic illness and a disability, and they've got a lifetime of trying to connect with other people who've had a stroke. So we have a young stroke survivors program that runs of a Saturday, in fact, so that people who work can come along, and it's frequented by quite a number of young people who come along. And the other thing that we run is online stroke support groups, where people who work and are younger can come along and learn a little bit more about stroke as well. So I guess there's a number of programs out there that provide good support for younger stroke, but I do agree it's an area that has been well under-resourced for quite a long time and needs a lot more resourcing.
And Michelle, if I could just keep you, Michelle, for a second, do organisations like yours also run online peer support, like the sort of thing we do?
Yes, we do. We run online peer support groups for new people who've had stroke. So it's called Stroke Chat, and that's we have them all on a Tuesday afternoon at about 2 p.m. We have groups that are about cognitive development and re-engaging with cognitive and that sort of thing. And we have support for carers on our online groups, as well as just general social connection for people post-stroke in an online community. And that's open to anybody from anywhere throughout Australia who can come along to that program anytime they wish.
Brilliant. And we might send out, with the feedback sheet that you'll get after this evening, we might send out information and a link to Michelle Sharkey's organisation because of that national coverage.
Can I just add just something there, Julie? The Stroke Foundation also has a chat called Enable Me that is worth, it's very similar to Michelle, but it's national. And actually, there's a lot of international people who access it as well, because in some countries they don't have those type of forums. And if you've got, want to ask a question on sexuality or incontinence after stroke or physical disabilities, there's a lot of forum chats that you can go into. It's called Enable Me.
Oh, Enable Me. I didn't hear that. Thank you. Enable Me. So if you Google that, or what else would you Google to find it?
The same as the iRebound. It's another sort of place within the Stroke Foundation. Enable Me, iRebound is in the same spot.
Thank you.
And in the future, Love Your Brain, once we finish the trial, will be part of that as well.
I love Your Brain. Honestly, brain is time, or time is brain. Lena, another question, please.
This is an interesting one. Is there a difference between men and women in terms of how they go through the experience of a stroke and eventual recovery?
Can I come to Professor Thijs, and then I might ask you, Monique, whether any of your big data offers insight. Professor Thijs?
Yes, there are differences. There are important differences amongst the risk factor profile, the age at which a stroke, but also how stroke affects the men versus women can be quite different, because the social support can be different, especially if you're at a different life stage. We know that our female stroke survivors are generally older. They are less likely to have a partner. So there are many things that can be different. In terms of the presentation, the treatment, there should not be a difference. We know, however, that there seems to be gaps, that there are under-treatment of women. There's less focus on prevention. There is often delays in accessing hospital for women versus men. And so that is a really important area of focus. And some people are really experts in this. In New South Wales and in Sydney, there is a lady called Cheryl Carsell who works on this topic as a worldwide expert on disparities between men and women in stroke care. Also in research, we see that fewer women participate in research, and it's really crucial that we focus more attention to females that are having a stroke. And I'm sure that Monique and Coralie will have additional comments because I think this is a topic close to their heart.
Well, thank you. Well, can I come to Monique first. Obviously, the question I'm interested in is why there may be there is a difference between the treatment responses to men and women. But your comments, Coralie, what do you think is the important things to say? If you could turn yourself on.
Oh, look, I think, Monique will have some information about the data. I think, you know, I could get on my feminist soapbox and have a bit of a rant. I won't in terms of time, but I think, you know, we're a lot better than other places. India, it's absolutely shocking in terms of the women who get to hospital. But I do, you know, I think there's a lot of bigger societal things at play here in terms of people being recognised. And we don't know enough about the impact of menopause on stroke either. It's not been well researched and good of menopause. So it's just one of those areas, like many other areas of medicine, where we're lagging behind in understanding what the disparities are with women. Yeah.
Thank you. And Monique, your thoughts?
Yes, so it's sort of reiterates what Vincent was saying, that there are sex differences in quality of care as well as in outcomes. And I think with the imbalance in care, it is often, I think, that these women, they're older and they're on their own. And so they don't have a patient advocate to advocate for them, to make sure that they leave the hospital with all these medications to help them in their discharge care planning. And so that's why we do find that there are differences. Women are missing out on going home with their medications if they are alone. So maybe we need to start thinking about some interventions to make sure that there's a support person with them when they're leaving the hospital.
But surely those characteristics would apply to men living alone.
Definitely.
But so is there a disparity if you compare men living alone to women living alone?
I don't know. That's a good question. It's more often that it's women alone than men alone.
I only ask because I had head and neck cancer, as I mentioned, which is predominantly many more men get it than women. And there's evidence that men who are single have a lower survival rate. I can even remember my partner was with me when I was diagnosed, and the doctor gave me my chances of survival and said, but don't worry, you've got social support, pointing towards my weeping partner, and you're overweight, which in head and neck cancer is actually a positive because the treatment stops you eating. Only because the treatment stops you eating. It's the only time you want to be overweight is if you're diagnosed with head and neck cancer. But no, that's absolutely fascinating. But look, I want to take the opportunity for one more question, if I may, unless Malcolm, would you like to comment there?
Oh, look, the only thing about women is that for younger women who have stroke, particularly if they have children, especially if they're unpartnered, that's a real challenge. It's something I've had to deal with a number of times and try and manage.
And I can feel in my bones that Wolper Jewish Hospital will give equal access to care and concern to men and women.
I would hope so.
But if we've got time for one more question, Lena, or maybe two if we can.
Sure. So just to finish with rehabilitation, is there such a thing as optimal timeline for complete recovery?
Good question.
Wow. Listen, may I come to Malcolm first, and then will I come to Coralie? It's my instinct. Malcolm, what's your quick response, if you could, sir?
Optimal time frame for recovery. Look, the recovery from stroke is quite complex. I guess there's two things we consider with recovery. There's recovery of the brain and the function, what the brain is doing for the body, and then secondly, there's the relearning of particular tasks, I guess. The recovery from stroke it can be difficult to predict because it's not linear. It doesn't sort of go in a straight line. We tend to see sort of more recovery early on, and then it tapers out over time. And so you sort of see most of that recovery in those sort of first weeks and months, and then a slower recovery after a few months, I guess. So as far as rehab goes, we try and do as early as possible and as intensive as possible in those early stages. I guess that's what we know from the evidence. If that's a short answer, yeah.
Thank you very much. And Coralie English, would you like to offer a comment there on recovery?
Absolutely. We know that the fastest recovery happens in those first 3 months, but we used to say after that you won't recover any further, and we know now that's completely wrong.
That's correct, yes.
You've got a window where your brain is most malleable to change, where the more is better, but there's always room for change. And I hear from my stroke survivor research partners a lot about years on, I've now can do this thing that I couldn't do before. So it's ongoing, it's lifelong, and you can still make gains no matter how far you are down the track.
Monique Kilkenny, would you like to comment on that?
I just love what Coralie was saying. I think that's fantastic. You know, never give up hope, be determined, keep going. You know, you can still make changes in 1 year, 2 years. So that's great news.
And I guess we're extra lucky if we have a caring partner or family member who can assist us to keep that motivation, even for incremental change. But Professor Vincent Thijs, I want to come last to you before we close down. Is there anything more we need to say or anything you'd like to emphasize as we come towards the end of our session?
Well, I think it's important to talk about stroke, to make it known. Talk to your grandchildren, to your family members, learn to recognize the fast message. Those are things, and then try to work on your lifestyle. It's never too late. I think those are the important messages, I think. And well, support people that have had a stroke. They're going through a difficult time, and it's their love and affection and their care that will help them. So I think those are my messages.
Look, thank you so much. And I remember when you began, it's a lifelong process, prevention. And I actually have 2 grandchildren, and their parents have bought them this amazing jungle gym that they've got in the front of their yard. And this little 4-year-old, you know, can already leap along the bars and do the full length. And so I'm going to keep encouraging her to do that. So she's getting onto her stroke prevention. But look, just because not being sedentary is so important. Before we close, can we all, if you can, stand up? So it's that visual reminder that we need to stand up. And I will go and have a very light meal, mainly based on salad and fresh vegetables. And I want you to know that at 9 o'clock tomorrow morning, I have an appointment under my chronic disease management plan with my exercise physiologist. And I am recommitting to him after this reminder of the session. But ladies and gentlemen, on your behalf, I would like to thank Professor Coralie English, Professor Vincent Thijs, Professor Monique Kilkenny, and Dr. Malcolm Bowman from Wolper Jewish Hospital. Deaf sign clapping to you all. And thank you so much, Lena, for bringing as many questions as we could from our audience. And a reminder that this is